Hello, I'm Paula Casademunt, and I'll be discussing about valve flattening with functional biomarkers for the assessment of mitral valve repair. Hence, I will briefly introduce the mitral valve regurgitation, and the edge-to-edge repair. Then, we will see a quick overview on the methodology, that is, how the interventions were modeled and visualized. Moving on, I will show some of the results and conclusions extracted from them. Let us start by a fast reminder on the mitral valve. It connects the left atrium with the left ventricle, ensuring unidirectional flow. It opens during the diastole and it remains shut during the systole. To prevent the prolapse, several tendons are attached, linking the valve to the papillary muscles of the ventricle. Mitral valve regurgitation is defined by a retrograde flow of blood from the left ventricle to the left atrium. We find two main types of regurgitation. Primary regurgitation is a result of an intrinsic lesion of the mitral valve apparatus, while secondary regurgitation is caused by abnormal changes in the geometry of the left ventricle, displacing the papillary muscles or dilating the mitral annulus. Both types of mitral regurgitation are considerably hard to treat due to several reasons, and in this scenario, percutaneous therapies for both cases can offer new alternatives, increasing the likelihood of successfully treating even the patients with more complex presentations. The most common percutaneous therapy for mitral valve regurgitation is called edge-to-edge repair. It consists of clipping the mitral valve leaflets, converting the valve into a double orifice valve using the Alfieri stitch. Doing so, surgeons re-establish leaflet coaptation and decrease the regurgitant jet. If the clips are not correctly placed, there is a risk of reintervention. Furthermore, the exact placement of the clip can influence the results. Considering the need for a proper planning to ensure satisfactory outcomes, a pipeline toward clinical decision-making could be of great use. This is where computational modeling comes into play. This tool has gained importance in the last decades to assess safety and efficacy of cardiovascular devices. Lots of studies has been done in the last decades to understand the valve dynamics using finite element models, including fluid structure interaction models that study the valve as the flow passes through it, even models for the pathological mechanisms of the mitral valve, and other simulations of several repair techniques. However, all these studies have one thing in common. They are all mesh-based techniques. Considering the range of deformations and distortions a valve undergoes, as well as the contact between leaflets, meshes give a lot of issues. Although mesh-based methods are more mature, meshless methods such as smooth particle hydrodynamics or SPH can overcome these limitations. Hence, the main objectives of this work are modeling 3 different types of mitral valve regurgitation, modeling the edge-to-edge repair technique, and implementing a valve flattening visualization methodology to ease interpretation of the results. Just as a quick introduction on SPH, the domain is divided in a set of moving particles with no connectivity among them. However, they do have a neighborhood, defined by the kernel function. To use SPH for continuous mechanics, 4 equations need to be solved: the conservation of momentum, the deformation gradient tensor F, the continuity mass equation, and the constitutive law for a quasi-incompressible neo-Hookean material. Furthermore, to use SPH to model the mitral valve, we will have to take into account the contact between non-neighboring particles using the algorithm proposed by Wong et al., as well as defining the subvalvular apparatus of the valve, that is, the cords that prevent the valve from prolapsing. This will be done by means of springs. As for the boundary conditions, we will apply a transvalvular pressure from one side of the valve, accounting for both the atrial and ventricular pressures at all times. Furthermore, the papillary muscles motions throughout the cycle will be accounted for, and the annulus particles will be fixed to keep the valve in place. Besides the healthy mitral valve, 3 pathological cases were simulated. The first one was the primary regurgitation, and it was obtained by reducing the stiffness of the springs of the P1 scallop. Traumatic regurgitation was modeled by removing the cords that had a reduced stiffness in the previous case. And for secondary regurgitation, since it implied a remodeling of the ventricle, this was portrayed with a displacement of the papillary tips and a dilation of the mitral annulus. As for the valve repair techniques, the edge-to-edge was simulated by linking several particles from opposing leaflets to each other, using springs with the length of 0 until reaching a width of 5 mm, accounting for the clip. These 2 clipping positions were assessed. We aim to depict the results of the simulations in a fast and easy way, without the need of a costly pre-post processing of the results. Hence, we use the flattened view of the mitral valve that allows the analysis of the whole geometry in one go, and can be color-coded. For instance, it can help to identify which parts of the leaflets are not achieving total coaptation when they should. This was done following the paper shown in the slide by Lichtenberg et al. The first step of the flattening is the annulus parametrization. In this step, a plane is built to then map the height of the annulus in 2D. The plane goes through the commissure point of the annulus and the very center of the posterior annulus. All the points that fall within the plane will have a value v equal to 0. Then, the annulus is plotted in 2D, taking into account the distance between it and the plane. The next step consists in placing the leaflet geometry below the annulus. To do so, we have to use the spline-like lines. Each point within this line shares a u-coordinate, and the distance between points is preserved vertically. Finally, the geometry is optimized to achieve a more area-preserving flattening. This is done minimizing an energy term describing the distortion of the distance between particles. So, following these 3 steps, we can find a correspondence between 3D points and 2D points and eventually obtain a 2D mesh. Moving on to the results, these are the 4 pre-interventional simulations. On the left, we can see the healthy valve, achieving proper coaptation at peak systole and without any apparent prolapse. The following one, with the primary regurgitations, shows a P1, P2 prolapse, indicated with the arrow, that is exacerbated in the traumatic regurgitation scenario. Finally, as for the secondary regurgitation, we can see how the valve cannot properly close due to the remodeling. Due to time limitations, I will introduce the results of the edge stretch repair technique on traumatic regurgitation. However, the outcomes of the intervention in primary regurgitation were qualitatively similar. The first simulation accounts for a properly placed clip, located in the site where the regurgitation occurs. No prolapse can be identified, and the dynamics closely resemble the ones of a healthy valve. However, placing the clip in a random position can even worsen the condition, having larger regurgitations than previously. This is where the flattened views come into play, allowing an easy analysis of the intervention results by means of the contact, curvature, and stresses. We can see how the diseased valve lost the contact precisely in the region where we had the regurgitation, in the P1 scallop. However, a properly placed clip can almost ensure full coaptation, recovering the lost contact, while if the clip is placed in a suboptimal position, it can have close to no effect. The curvature of the valve at peak systole can give information regarding the structural distribution of the leaflets, and can give an indicator of how close the valve is to its healthy state. For instance, we can see a closer resemblance of the valve between the post-interventional valve and the healthy scenario. Once again, a suboptimal placement of the clip will have close to no effect on the curvature of the valve at peak systole, resembling the distribution of the diseased valve. Also, we can appreciate a decrease in the stresses in the diseased valve and a minor increase of the stresses in the post-interventional regurgitant leaflet. We can compute the differences between simulations that can offer relevant information and help the comparison between states. For instance, in the lower right figure, we are comparing the differences in stress between the post-interventional valve and the disease scenario. A 200% increase of the stresses in the prolapsed leaflet is identified, re-establishing some of the lost stresses. This project is not without its limitations. There is the need for a better personalization of the simulation, as well as a bigger study of the generalizability of the pipeline proposed in this work, together with the sensitivity analysis of the parameters used in the SPH simulation. Overall, this project shows the potential that SPH has to model and predict the dynamics of the mitral valve and the repair outcomes. Furthermore, the flattened visualization has proven to be an extremely valuable asset. It allows us to identify the prolapsing region by seeing where there is no contact, as well as an extremely relevant stress distribution. Moreover, this is the first work that uses the curvature as the measurement of analysis, that can give very important information regarding the pathological condition of the valve. Hence, the pipeline proposed in this work can become the first steps towards the implementation of patient-specific modeling software to aid in the clinical decision-making process for the treatment of mitral valve regurgitation, the second most common indication for heart valve surgery in Europe. Thank you very much for your attention. If you have any questions, please do not hesitate to ask them.